Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Today, our topic is progesterone, and we'll be joined by Dr. LaKeischa McMillan. Because I am somebody who studies history and thinks that history is really important so we don't repeat the wrong history, I would like to start this discussion by giving a little talk about the history of hormone replacement therapy, specifically in the United States. So, hormone therapy replacement today continues to be controversial in the mainstream medical community. And when we go through this, you'll understand why. So, part of this discussion of the history comes from an article I recently read in Circulation. It's from 2023, and it's called Rethinking Menopausal Hormone Therapy: For Whom, What, When, and How Long. So hormone therapy, or replacement hormone therapy, abbreviated HRT, started during the Great Depression with estrogen derived from the urine of pregnant women. In order to save money, this was replaced with estrogen derived from the urine of horses, referred to as conjugated equine estrogen, which I think is outrageous. Such therapy became gradually more popular. And after the popular book, Feminine Forever, published in 1966, which proposed that menopause was a state of hormone deficiency that led to painful intercourse, the loss of sex appeal, and youth. This, combined with the changing status of women, the feminist movement, HRT became increasingly prescribed, with annual prescriptions exceeding 50 million by the 1970s. But then some studies showed that just taking estrogen increased the risk of endometrial cancer. And this led to a decrease in the use of HRT until it was discovered that if we combined progesterone with estrogen, this protected the uterine lining. Then in the 1990s, several studies, including the Nurses' Health Study, showed that HRT reduced the risk of cardiovascular disease. This led to an all-time high of 90 million prescriptions of HRT in the US. But then the infamous, and I use the word infamous carefully, Women's Health Initiative study was published in 2002. And this showed that those who took oral conjugated equine estrogens and medroxyprogesterone acetate had an increased risk of breast cancer, heart disease risk, stroke, blood clots, leading to an approximate 80% decline in prescriptions for HRT in the US and a similar decline worldwide. Since that study, there have been a number of looking back at the Women's Health Initiative study, reanalyzing the data, and there have been a number of studies showing that when prescribed in the proper form at the proper time, that the risks of HRT are minimal at worst or don't exist at all. To help us sort out some of this information about HRT, and in particular, I wanted to focus today's talk about progesterone, which doesn't get talked about as much as estrogen. We have asked Dr. LaKeischa McMillan to join us today. Dr. LaKeischa McMillan is an integrative OBGYN. She graduated from Loma Linda University School of Medicine, where my good friend Dr. Risto Vashtani also teaches. Dr. LaKeischa wrote a best-selling book, The Other PMS, Your Survival Guide for Perimenopause and Menopause. And she lectures frequently on perimenopause, and menopausal health and hormones. On social media, she's known as the hormone hottie. So, Dr. LaKeischa, thank you for joining us today.
Thank you so much for having me here. And I'm so excited to be here with your community. I always love coming into communities that already have this foundation of wellness, a conversation that's already going. And so I feel so at home to be able to just jump in and kind of, give some more of my opinions as well as facts and be able to help build this foundation even stronger. So thank you for the invitation for having me here today.
Absolutely. I just wanted to mention something on my mind. One of the reasons I wanted to read that intro was because in thinking about hormone replacement therapy, I thought, I can't believe that we are giving women hormones from horses. And I just thought, you know what? If that was proposed to men, yeah, we're just going to give you hormones from horses. There's no way that would have happened. But anyway.
You said it. I mean, seriously, yes. And I was looking back at kind of like the social construct of menopause, and I think that's part of it as well. I remember doing a CME a few years ago, and it took me through the history of how we even looked at menopause. And I think that's part of the story too, is that it began in the 1600s of looking at it as a moral, failure on women's parts. Like all of a sudden you weren't holy enough, you weren't doing your part. And so you had this wandering organ that started wandering about your body, causing hysteria, right? And so we have to be able, this is why I love these discussions, because this is another layer to that foundation, right? And then, we're like you said, it was like, oh, we think we found the fountain of youth. This estrogen seems to be the answer to all the questions and all the problems. And I think that's when we get in trouble, when we think we have this panacea, when we think we have this utopia, we have the one thing, and we stop looking at somebody as a whole person and being able to address that whole person. So I love the wellness part of your approach, your practice, your discussions. And you're right. If we had said to men, hey, let's make this, cheaper so that we can manufacture it in mass. But you know what? We're not going to give you the biological equivalent. We're going to actually make a synthetic formula that can act the same way. So it's like we're making a different key that can fit in the lock, but we're not going to worry about what that key does after it turns on the lock, right?
Right.
We're just going to give you this synthetic form. And you're right. It was like, what are you doing?
Exactly. And even worse, what if we said we were going to take the hormones from a duck or something and give them to a man?
Exactly.
But some guys might be saying horse hormone, maybe I'll take that.
Absolutely.
Anyway, so I want to start by talking about progesterone and the benefits and functions in a woman's body, and then eventually make our way to the risks later on in the discussion.
Sure.
So let's talk about some of the benefits of progesterone. And I know one of the things that I heard you talk about in one of your discussions that I don't think is very well known are the neurological benefits.
Oh, I'm so glad you're starting this discussion here, because what it does is it actually helps to challenge an old paradigm that most physicians have been taught, which is women that have hysterectomies, that don't have a uterus, don't need progesterone. Because as you so eloquently stated in the beginning with the history, is that we were like, oh, there was a time where we saw progesterone helped with preventing that uterine cancer. If you just gave estrogen unopposed, then you had this outcome. And so there is this thought, oh, progesterone has only one benefit. But like you're saying, we are now understanding that the metabolites of progesterone, so progesterone can actually turn into what we call neurosteroids. And those neurosteroids cross over the blood-brain barrier and go into the brain and interact interact with neurotransmitters, and it can impact the serotonergic pathway, dopaminergic pathway, cholinergic pathways. And so what are we looking at? Progesterone can help with pain. We know that there have been studies that actually looked at progesterone being a form of an analgesic because we know it has those properties. It was actually, I know in my OBGYN literature back, in a historic literature, they actually looked at it to actually administrate it to women in labor, but the half-life is very short. It wasn't that, powerful. So it was not a long-lived option for labor and delivery. But we know that progesterone can be helpful with our own pain pathways. It can actually help to block some of those COX pathways, the COX-2 inhibitors and those type of pathways. With the prostaglandin pathway is actually what it interacts with. So then it can actually help women that may have issues with having pain with their periods. So that's only one of the things that progesterone can do. It can interact with the serotonergic pathway, which helps with our mood, which helps with making, it interacts with, say, the GABA pathways and making sure that it calms down that shoulders raising up to our ears, that, okay, everything's okay. You don't have to be so super anxious, those type of things. So that is one of the benefits that progesterone has, just a few of them. And a lot of people don't talk about it. And what I see in my work with helping with perimenopausal and menopausal women is that when I give them progesterone, they go, oh, it's almost like you see it just in their face. They just, oh, thank you. I feel so much better.
Yeah, I have two thoughts I wanted to touch on, both of them. One is when you talk about the fact that progesterone metabolism leads to these neuroactive steroids, it would be really cool if, like, Dutch testing actually measured those neuroactive steroids. Wouldn't that be cool? Because we get so much into the metabolism of estrogen, but we don't learn that much about the metabolism of progesterone. And this would be very cool to look at.
And it really would.
And then the other question I have is about the idea of possibly using progesterone for men, because I've had a discussion with neurologists about using progesterone after a brain injury. And there is good data showing after a traumatic brain injury that progesterone can have some benefits. And I'm sure it must be related to these neuroactive steroids.
That is a very interesting and promising area. I'm so glad you brought that up. That actually just made my brain start ticking. I was like, ooh, yes, that actually sounds really great because, again, it can help with the analgesia. It can help with the cholinergic pathway. It can help with the serotonergic pathway, the dopaminergic pathway that can help with that reward pathway and that focus and being able to help these various brain structures literally heal or actually give them protection as they heal. So there's so much that could be explored through that. I love that. I love that discussion.
So besides neurological, what are some of the other benefits of progesterone?
So progesterone also helps, of course, women, if we go back to the basics, I always like to start there. It helps you to have a set interval of your cycle. So it helps with that 28, 30, 32-day cycle. I always say, think of progesterone as being in charge of the lawnmower service. So what happens is if you think of your period in terms of grass growing, the estrogen helps the grass grow tall or proliferation of the uterine lining. Progesterone kind of holds back the lawnmowers until it gets the signal, was there an egg fertilized or not? If it doesn't, if there was no egg fertilized and it says, okay, guys, we're going to help mow the lawn in 2 weeks, right? So it helps to make sure that, one, your breast tissue doesn't get overstimulated by estrogen as well. It also helps to make sure that you have this nice type of increase or crescendo, decrescendo of your hormones during that set interval. And progesterone also helps with metabolism. So we know that it can help with making sure that your body is able to, it helps with the kidneys and helps them to dump off oh, sorry, I'm getting all tongue tied here, y'all, because I have so much going in my brain.
Well, benefits of progesterone for the kidneys.
It has protection so that you can actually dump all the metabolites that you're not using, so it can get rid of those toxins as well. So progesterone has all these different types of jobs, I call them, that progesterone will do.
Right. And it works as a perfect companion with estrogen.
Absolutely. Absolutely.
So when you prescribe progesterone, it's common for doctors to give women progesterone every day of the month. And they assume that most women don't want to get a period anymore. And it's not surprising. And I suspect that a lot of women don't want to get their period. But what is the best way to prescribe progesterone to menopausal women?
That's a great question. Okay, so to menopausal women, I actually look at the individual and I'll look at their testing and their symptomology. So if they're having issues, so if they're menopausal, which means they're not having a period anymore, they've gone through that transition, then I will prescribe a low dose of continuous progesterone if they can tolerate it. That's the other thing, because if you do a continuous progesterone type of preparation, you can actually downregulate estrogen receptors, and they won't get the benefit of the estrogen that they have on board. So then they can represent with either an intensifying of their vasomotor symptoms, or they can have a surgence of that where they didn't have it before. So that's where I say, look at the individual, see what their symptoms are, and look at their tests that you've decided to run. If they are perimenopausal, which means that they could be still having a cycle, it could be this intermittent, or it could not be a regular interval, then I will say, hey, let's go ahead and create a set interval, which means we either look at if you can map out your cycle now and we can find the luteal phase, then we can do that and just support the luteal phase. And that will be where you cycle your progesterone. If you can't, then I say, let's make one. So then we look at the calendar, and I find it easy just to follow the calendar days. And so in the beginning, I have to counsel them that it's going to be a little rocky road. You may have some intermittent, irregular spotting, but about month 2 to 3, it may start getting in a set interval. And that way we can create this luteal phase that's supportive.
What about doing that cycle mapping testing from Dutch that helps you to?
Absolutely. You can absolutely do that. You can do the cycle mapping. I do cycle mapping, though, with my patients if they are having an interval. If they're having a set, if they're still having cycles pretty consistently. When I say consistently, I'm saying if they haven't had a gap if they have like a 6-month gap, they haven't had a cycle, then I say, well, let's just do the Dutch complete, where I look at we just look and see what's going on with how you're metabolizing them. But if they're like, oh, I have one maybe like every other month or every 45 days, and I say, yeah, let's do the cycle mapping so we can see what's going on in your cycle, in your interval.
Now, when looking at hormones, measurement of hormones, during perimenopause, they tend to be a little bit all over the place. So how do you decide this patient needs hormones or how much hormones, given the fact that it's sort of erratic depending upon when you measure it?
That's a great question. This is where the art of medicine comes in. And This is where I sit and I really dial into what they're experiencing in terms of their symptoms, what is the most impactful in their life, and where are we trying to go. And so then I take my expertise and put that into the mix too. So what I've come to find is that when you have a perimenopausal woman, say for instance, her biggest issue is sleep. and she's not, and say she's having an erratic cycle. So she's now having this cycle that is now spacing out, it's now, further apart. I will say, hey, maybe we should do a little bit of continuous. And when I say a little bit, I'm talking low dose, maybe starting at 12.5 milligrams or even 25 milligrams, titrating up just slowly. And then when she feels the difference, because most women can feel that change in their hormones, and she's like, oh, my sleep is now interrupted again. Maybe she doesn't have enough progesterone. Then I'll bump it up a little bit for just those 14 days and then come back down. So it's more of, this is where the art comes in. Like you said, their hormones can be all, like we say, all over the place. We can have this cycle that we're looking at, and we're not sure where we've caught them in their cycle. So I really have to explain, this is what I'm doing. This is how this may show up for you, because you may have some intermittent spotting. It may take us a month to get everything in order. So it's really a matter of setting the expectations of why I'm doing what I'm doing and what to expect and how long it's probably going to get us to get you feeling back into your own body again.
So with respect to testing, what kind of testing do you like to do?
I do a combination. So I will look at the Dutch testing, the urine testing for the metabolites, because I want to see how your body is metabolizing. I want to see what pathway your body actually likes to favor. I like to see if you need some certain types of minerals or organic acids that will help those different pathways. I also know that your gut is very important in the metabolizing of your hormones. So I want to make sure your gut microbiome is intact. So I will actually have patients do a gut testing and look at their microbiome. And I look at your thyroid, because I know the thyroid sometimes gets taxed with everything else that's going on. And I want to make sure that we're not missing something that could be thyroid related that has an overlapping symptomology with hormone depletion.
So for younger women who say have some hormone issues, can we increase progesterone levels naturally? Is there some benefit with using chaste tree or maca or other herbs or inositol or healthy diet?
Oh, you are speaking my language. Oh my God. If you have a video portion for your podcast, people will see me clapping on screen. You are saying everything.
Yeah, it's on YouTube as well.
Awesome. Because yes, the straight answer is yes. So if I do have patients that are early perimenopause, when I say early, they're like maybe in their late 30s, early 40s, and they are having some extreme symptoms. One, we have a really frank conversation, and I ask them about their life. I ask them what is going on, and I need a timeline of what has happened. How did we get here? And then I say, okay, do the testing. And when we do the testing and I review the testing and I know the information that they've given me, then I'll say, okay, you could be a candidate for doing some natural, like maybe even seed cycling, doing certain seeds at certain times in their cycle to help boost their own natural progesterone, along with those herbal supplementations. Because we know that the adrenals, when they get pulled on, they actually can interrupt the entire system. So all that you've said, yes, I utilize all of that. I use maca root. I will use adrenal. I'll use ashwagandha to calm down the adrenals. I'll even use licorice root for those that are a good candidate for licorice root to convert their cortisone to cortisol so that they have the right fuel on board. So that while we're doing this and taking care of the ovaries and making sure that they can produce, we haven't neglected other areas that are under attack as well.
Yeah, like the adrenals.
Mm-hmm.
Let's see. When you prescribe hormone therapy, what type of hormones do you like to prescribe, and in what form, and how do you like to cycle it or use it consistently, etc.?
Oh, wonderful question. I really like using something that's transdermal. We know that if we use the skin and we bypass that first pass metabolism, that's usually the best, right? Now, progesterone, you can use bioidentical progesterone that is in an oral form. I usually use that from a compounding pharmacy, and we know that that can actually help with the uterine protection. But there are some patients that just can't tolerate capsules. They don't do well with it. They don't like it. And so I will use a cream or suppository form. So I'll use cream form, suppositories, patches. I've even done pellets where you place that little pellet right under the skin and let the body naturally utilize it as needed. But the dosing really is based on the patient's labs, what I see in those labs, especially the gut, and making sure that I don't overload the system and it can't process what I've put inside.
When it comes to estrogen, you use estradiol or do you use
Yes,
bias?
I use estradiol, but I do there are times I'll use bias. So I'll use estradiol if that person is if I do the Dutch and I see that they are not pushing towards that estriol pathway, because some people naturally push to the E3 pathway. And when they do that, it actually E3 is not that estrogenic, but it kind of takes up space is the way I think about it. And I'm like, okay, I don't necessarily need you to make more estriol. I really want you to make the estradiol so that you can utilize that and feel the difference. So that's when I'll say, if I see them making more E3 naturally, I will just use estradiol. But if they're not making too much of that through the Dutch, and I see the gauges are saying which one, which type of E1 that they're making, then I may do an 80-20 or a 50-50. I have one patient now, I think about it, and she was at a 50-50. And I was like, oh, let's try 80-20 because I looked at her stuff. She wasn't making that much E3. And I switched her to 80-20 and she didn't do well on it. Like her body just liked the 50-50. So we had to put her back on that. So that's another thing. Really listening to your patients when they come back and tell you, I don't feel good on this.
I've really been enjoying this discussion, but I just want to take a few minutes to tell you about a product that I'm very excited about. Imagine a device that can help you manage stress, improve your sleep, and boost your focus, all without any effort on your part. The Apollo wearable is designed to do just that. Created by neuroscientists and physicians, this innovative device uses gentle vibrations to activate your parasympathetic nervous system, helping you feel calmer, more focused, and better rested. Among the compelling reasons to use the Apollo wearable are that users experience a 40% reduction in stress and anxiety. Patients feel that they can sleep. Their sleep improves up to additional 30 minutes of sleep per night. It helps you to boost your focus and concentration. And it's scientifically backed. And the best part is you can get all these benefits with a special $40 discount by using the promo code WEITZ, WEITZ, my last name, at checkout to enjoy these savings. So go to Apollo Neuro and use the promo code WEITZ today. And now back to our discussion. Yeah, I know some doctors are real big believers in estradiol and feel that that's really the hormone they should be
Yeah,
taking.
I think it really is a matter of the art, because you have to remember that if you think of it this way, I think of it as putting something on a conveyor belt. And if I put too much and the conveyor belt speed is slow, then I'm going to have the Lucille Ball type of situation, right? Where you have all these chocolates coming down the conveyor belt and you got to stuff the chocolate somewhere because you don't have the containers ready, right?
Right.
So that's the way that I'm thinking. And then I also use testosterone. I think testosterone is is woefully underutilized in women. And we know that there are some papers that have come out and they've said, well, testosterone is great for overall well-being. Well, what does that mean? That's like your mood. That's like motivation. That can be focus. And so when I tell women, you make testosterone, they're like, what? They're like, really? I'm like, yes. And you make it in your ovaries and in your adrenals. And so your body needs that. And when I give them some of that testosterone, they're just like, ooh, I feel so much better. Like energy wise, even I feel like I can be myself again.
What about pregnenolone, DHEA?
Oh man, yes. I use that in my perimenopausal women more so because in the way that I'm thinking, it's actually helping to stimulate what they can still produce.
The precursor.
Exactly. So it can be taken in the body and the body can say, oh, I know what to do with this. I want to make this. They don't have enough of progesterone. They don't have enough of the testosterone because you remember the pregnenolone was like that parent molecule. And
Right.
so it can go down. I call it the plinko. So it'll go down and it'll go wherever it's needed. And that is why I like that. I like DHEA. I like a small dose of DHEA for women because DHEA tends to go down the androgenic pathway and you don't want to make those heavy androgenic hormones. I just was joking with a patient earlier and she was like, oh, well, can I just go ahead and up my DHEA? And I was like, well, now let's do that gingerly because you don't want to become this pimply hairy person, right? She's like, oh yeah, no, 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 no. So yes, I use those as supports to help the system be able to do what it needs to do.
Right. So, what about the benefits of natural progesterone versus synthetic progestins?
Oh, that is such a huge topic. So I have to go back to something you said in the beginning, which was that whole WHI study.
Yeah.
And I feel like I have a special connection with that study because I was an intern.
Oh, okay.
That study came out in July of 2002. I just started July 1. And we is the middle of July. My program director, we're sitting there, morning report, waiting for her to come through the door. She walks in waving this paper like, this was FedEx to my home. Oh my gosh. We have to stop everybody. We have to stop. And what happened is that if you look at it, so now I've been practicing for 20 plus years now. My initial uh introduction into being a full-fledged doctor is don't do this anymore. It's bad, it's bad, it's bad. But we didn't have the ability and the support systems in place for us to go back and dig into that information and find out. And I'm saying all this to say the progesterone that was studied in that study or was given in that study was a progestin. And so we have this nomenclature that if anything has this chemical structure that looks like this, we call it progesterone. And that's where a lot of the confusion can come about. So when you're talking about this to your patients or colleagues, you really should say, is this a progestin or a progestogen? So a progestin is that synthetic. This is the one I was talking about earlier that is made to look like progesterone. It can fit in the receptor. It can kind of turn it on and make it do some things. But then when the body breaks it breaks it down into these metabolites that the body has no idea what to do with. Versus your human progesterone and your bioidentical progesterone, which looks chemically just like what your body used to make. It fits in the receptor. It turns on the receptor. It does what it needs to do. It breaks down to the same metabolites. Your body takes it and goes, oh, okay, this goes over to the kidney. This goes over to the GI system so that we can get rid of them. And that is why it's really important to know the difference. And that's why I take time with my patients to help them understand bioidentical versus synthetic versus the medroxyprogesterone acetate, what's in your birth control pills, what's in your IUDs. These are, yes, we call them progesterone. They're under the same umbrella, but that's just for nomenclature and for us to be able to do our studies. It does not give you the full story of the molecule.
So where are we in terms of safety of HRT, considering the Women's Health Initiative, other studies, et cetera? And, is the main problem with the Women's Health Initiative, is it the timing hypothesis? A lot of people criticize the fact that most of these women were not put on hormones till 10 or more years after menopause, and some of the cardiovascular disease risk had already occurred because they went that period of time without the protection of estrogen, or is it more about the fact that they were using these synthetic forms, horse estrogen and synthetic progestins, or is it really the fact that whatever increased risk of breast cancer was there was very, very small anyway? What do we do with, and where are we? What do you tell you women? Is taking bioidentical hormone replacement therapy, does that increase your risk of breast cancer?
I'm going to answer that last question first, and I'm going to say no, it does not.
Okay.
Learn that does not increase your risk for breast cancer. Now let's go back and look at the study, like you said. So now what we learned is that when they went back and looked at the statistical analysis, the statistical significance of that breast cancer, what looked like a breast cancer bump, was not statistically significant above your risk of just being a woman. So there were a couple of cases, but when they did all of the analysis, the statistical analysis, there was not an increased risk. There have been subsequent studies, like you said in the beginning, that have looked at bioidenticals, that have looked at the studies, that have re-evaluated the data. And we're saying what we need to help people understand is that hormones do not cause cancer. There are some cancers that can be fed or augmented by certain hormones. That's what we need to understand. But bioidentical hormones are not the ones that can do that. We need to make sure that you differentiate that study was synthetic. We don't use those anymore. Like if somebody is trying to give you Premarin, no, absolutely not. The bioidentical ones, and this is where I stay a lot of my time in teaching, is that it's bioidentical. It looks just like what your body used to make. It breaks it down the same. It does not increase your risk. There's so many other life factors that do. And we need to look at that as a whole picture so that we can have that as part of a conversation as well.
And when it comes to cardiovascular risk, a big factor is not using oral estrogen.
Yeah, so the cardiovascular, I'm glad you said that. So when you use oral estrogen, what typically happens is that with first pass metabolism, you tend to make estrone, which is the E1 versus the E2. And then when you look through the Dutch test, if you use Dutch test to look at the metabolism, for some people, they push towards the 4-OHE1 pathway. And if you don't have enough of your anti-inflammatories, like your glutathione, your great antioxidants, they can cause that DNA damage that changes the DNA and can cause these cancerous cells to grow. So this is where this nuance comes in. This is why I really like adding the Dutch, so I can know intrinsically where your body likes to push things, right? And so that's why I do like to use transdermal estradiol, because the body usually takes it and breaks it down and makes the form that your body really likes and can metabolize and utilize correctly.
Are you familiar with this study that came out in May of this year? It was in menopause, and the title of the study was Use of Menopausal Hormone Therapy Beyond Age 65 Years and Its Effects on Women's Health Outcomes by Types, Routes, and Doses.
No, I need to get that.
Okay.
Tell me about
it's kind of a confusing study. It generally showed that hormone replacement therapy is safe in women over 65 years of age, but they had these different arms. And, one of the arms where they were taking progestin seemed to be safer than taking progesterone. So I don't know. It was a very sort of confusing study. Generally, it was showed that hormone replacement therapy is safe and beneficial, but it was a little confusing.
I'm going to have to look that one. I have you already going on Google Scholar right now. Like, wait,
okay.
Because so one of my philosophies is that I believe, depending on your patient's their lifestyle, what they're looking to accomplish, that hormone replacement therapy, or I like to call it BHRT, is going to be a part of their lives longer than what we have initially said, because of all the benefits, especially the osteoporosis benefit, preventing osteoporosis. Because
that's a big deal.
It's huge. We know that is the number 2. It's cardiovascular for women. When we're talking about morbidity and mortality, it's cardiovascular number 1, osteoporosis number 2, and then breast cancer. And breast cancer, I always say, has a great PR department. That's why a lot of people think it's number 1, right? So when
far more women die of heart disease exponentially.
Exactly.
100 times more.
And when we look at what these hormones can do, and I tend to think the way that they were looking at the WHI was like, hey, how can we prevent this? Oh, what happens that women's risk of heart disease goes up when their hormones go down? I think that was a great hypothesis, a great place to start, because we wanted to prevent these things from happening. And so I have a discussion with my patients saying, hey, I have marathoners, I have cyclists, I have people that are very, very active, and they're now pushing their 60s and mid 60s. And they're saying to me, okay, do I have to stop this? And I go, you know what? Let's continue to monitor. I believe in monitoring and seeing how your life changes so that we can be very responsible about this, but not just cut you off so that you decline significantly and rapidly.
Right. What you mentioned seed cycling. I suspect that some of the listeners are going to go, what?
Yes, seed cycling. And you probably hear me typing because I
so
love that.
So this is when you're taking certain kinds of seeds like flax seeds
absolutely.
and other kinds of seeds that have a different effect on different types of hormones, right?
Yes. So like I said, when you're in that perimenopausal phase, or if you are some of my, women that are still in their fertility phase of life, and they just need some help with making sure that their hormones are going where they should, I tell them about seed cycling. So days 1 to 14 of your cycle. This is where you have menstruation and to ovulation. You can do 1 to 2 tablespoons of ground flax seeds, along with 1 to 2 tablespoons of ground pumpkin seeds. And I tell them to go to like Mom's Organic Market or someplace that has them whole, where you can get them, and you can use your pestle, and you can actually ground them a little bit. You can put them over your salads. You can put them in your food. You can put them in your shakes. And so that's the first half, and that's going to help with your estrogens. That's going to support that phase. Days 15 to 28, or ovulation to menstruation, that's 1 to 2 tablespoons of sunflower seeds, ground sunflower seeds, and 1 to 2 tablespoons of ground sesame seeds. And this supports your progesterone production. So that's the seed cycling that I tell patients to do.
Cool. That's a great clinical pearl.
Wonderful.
So what do you think about pellet therapy?
I think it has a place. And I know that some people are all or none. I tend to live in gray areas. I like the ability to have some flexibility. And as somebody, and I can tell my own
in the
story.
Functional medicine world, we sometimes have to live in gray areas.
Yes. And my own story, I've done pellet therapy myself. I remember this was now 10 years ago. This was 10 years ago. I was 40 years old, and I had, been going through a lot of life changes. A lot of life situations had hit me, and I believe that really those stressors pulled on my physiology in such a way that it made me slam into perimenopause. And one of those things was my testosterone numbers. It was not even measurable in the bloodstream. And my adrenals were shot. My DHEA number was 37. It was horrible. And so I did pellets. I did 1 round. I did 2 rounds of testosterone pellets, but I'm one of those people that metabolizes towards the androgen, more androgenic hormones. And so I got the acne, I got the oily skin, my hair was shedding. I was like, nope, this is not it. Now, the benefits were excellent. I will tell you that, right?
Okay.
The benefits were excellent. But this is where the second round, so most people will do pellets every 4 months. So like once every 4 months. So when it was time for my next round, I went down in dosing, but still had the same level that it showed up in my bloodstream, still had the same types of symptoms of side effects. And that's when I switched over to creams. And the testosterone cream for me has been wonderful. It has really allowed me to build muscle again. I go into the gym and I feel the difference. My clarity of thought has definitely improved. My mood is better. And now that I'm, in that phase of life where I'm really going into that transition, it has really helped with sleep. I was out of my cream for a while. I started having a little warm splash in my face. I was like, whoa, what is this? So this is where pellets to me are for someone that knows they're not going to really utilize the creams like they should. Because creams, you have to be consistent. You have to take it the same time every day. And sometimes you may have to do multiple applications in the day to get your bioavailability in the range that is helpful for you. So that's why I say, there are different tools for different people. Now, the discussion comes around the levels at which some people are trying to have, women at, is this, they're going past the physiological range. And yeah, you feel great for a while. I will say, I mean, when my levels were really high, they were great. But then the side effects were something I did not want to deal with.
I want to go back to testing again for a minute. I have 2 questions. One is, what is the best way to monitor women who are taking hormones? There's some dispute. Some people feel that using salivary hormone testing is better to measure topical hormones. We have serum, we have Dutch urine testing. And then the second question is, I've talked to some practitioners who say there's no point in testing women's hormones after menopause because if they're low, period, doesn't matter.
Okay, y'all, this is one of my gray areas. This is where I'm going to sound like I'm sidestepping the question. So I'm just going to say it up front. So I feel that the practitioner has to know what they're looking for and what will change their management. So for me, I do Dutch testing, I do serum testing, and part of the Dutch that I do looks at the adrenals through saliva.
Right.
Okay. So I get all that, and I do the blood for thyroid. That's just an easier fit
Sure.
for
Yeah.
what I do for patients. Once they're on a regimen, if they are getting better and improving, I will do a follow-up of serum testing alone just to see what's available in the serum. If they are
does serum accurately reflect transdermal hormone use?
For me, it gives me a guidepost, so that this is what I was saying. So if they're doing fine and their levels were increasing and their levels were changing in the serum on the transdermal, particularly creams, because I have most of my ladies are on creams, if not all of them I can think of. And it does change in their levels on the serum. But then I have some where it stops working, like their symptoms get worse. Something happens and they're like, oh, I don't feel the way I used.
By the way, why do you use the creams versus the patch?
Oh, I use both. I'm sorry.
Okay.
I meant to say
Okay.
both. So
Okay.
it depends.
Okay.
I have some people where I started them on creams because it was just easier, I think, to
Okay.
start that way. And it's easier to titrate. And then
Okay.
it was like, okay, we've maxed out on this. Let's go to the patch. And they actually metabolize the patch better, you
Yeah.
know? So I will say that if they've been fine and then something happens and they're not fine anymore, then I'll go back to Dutch testing, because I'm like, something in the metabolic pathway has been interrupted. I'll go back and say, okay, what has changed in your life? Because clearly there's something. Either they went on a cruise, or they're selling their practice, or something has happened. There's a stressor, and that gives me more information. So I have a few in my I call it my hormone hottie handbag that I'll pull out and according to what is presented to me. But I say for practitioners, get a regimen that you are comfortable with, that you know it, and you know what you're going to do with the information. You have a protocol in your head, and I don't live just on protocol, but at least it gives me a foundation, and then I can make the adjustments and kind of change the levers that way.
And let's say you're working with a woman who's not taken hormones before and she's menopausal, and you measure her serum levels of hormones and they're really low. How does that guide your care? Does it
Oh,
change?
it at least will help me see what's going on from the adrenal side, because remember, the adrenals are should take over at least a little bit.
Right. Yeah, of
And
course.
I should see something happening in the bloodstream, and that'll at least guide me as to what I'm going to prescribe, the
Okay.
amount.
So even though their estrogen, their progesterone are low, there's a difference between being this low and this low.
Yes, to me.
Okay.
And what I've come to find over the years, yes, and what they're telling me. So I have
Okay.
some women that I would say, "Oh my gosh, you've been in menopause for say 5 years." And I'll ask them, "Do they have any vasomotor symptoms?" And they're like, "No, I don't have any. I don't have any hot flashes, night sweats, that vaginal dryness, the triad, right?" And I get their serum levels. Say if I used to just do serum only in the beginning before I did
Right.
Dutch. And say I got their serum levels, and I could notice their estradiol was not that below 5 register. It was actually like about 10. And I'm like, oh, okay. So clearly you're making enough that it's not impacting you symptom wise. Now, let's talk about, do you have enough on board for your cardiovascular, for your brain health, for your breast health, all of that? And that's
Right.
where we start. That's where the conversation goes from there.
So, what about women who've been in menopause, haven't been taking hormones? They've been in menopause for 10, 20, 30 years. Maybe they're even in their 70s or 80s, but they're struggling with sleep. They have other issues. Does it make sense to put them on hormones and or progesterone?
You asked some great questions. Great questions, because this is where I would probably people would probably go, why is she going to do that? Oh my gosh. But I'm just like, why are we letting women be miserable? So this is where I would start them on something, maybe the progesterone, a little bit of progesterone. And this is the person I would monitor even more closely, because they're older. And I want to make sure they're metabolizing everything okay, because I know that they have liver and kidney and all of these other systems have decreased in the way that their production and their performance. So, and it's interesting because I look at my mom and she's in her mid 70s and she had a hysterectomy in her 30s and she was never placed on any hormone therapy. And I look at all of her comorbidities now, and mainly it's heart, mainly it's cardiovascular. And I wish I could just bathe her in hormones now. I was like, oh my gosh. I even because she has some CHF, and I went down the rabbit hole and I saw a small study on how testosterone can be utilized in treating CHF. And I was like, oh my gosh. But of course, I do not treat my mother. So I'm respectful of her cardiologist, and they are wonderful. She has an amazing team. I mean, to the point where they even call me up and they'll, schedule stuff according to my schedule when I can get there. But I wish we had this information. And now I'm utilizing it for myself so that I can make sure as I age, I don't turn on certain genes that I know are in my line.
So sometimes in these women, you'll just prescribe progesterone.
We can start there. We can start very low. I have had a 70-year-old woman that could not sleep. Actually, her mind was just waking up at that 3 a.m. It was at 3 o'clock in the morning. So, of course, I was like, let's go down the blood sugar pathway. Let's make sure you're not bottoming out, having that phenomenon in the middle of the night where your blood sugar drops, And I was like, let me be mindful of the internal medicine side of things.
Right.
And she wasn't. It wasn't happening. And her hemoglobin A1C was great. Her fasting blood sugars were great. And I said, you know what? Let's try a little bit. Let's just try a little bit of progesterone. And I gave her a little testosterone, I think, at the time. And she came back and was like, thank you. She was like, I'm not sleeping like I did when I was younger. She was like, but at least it's better.
Yeah, I was just thinking of this one patient who has just horrible sleep. She's in her later 70s. But 10, 15 years ago, she had an unexplained blood clot. And as far as we know, there's no risk factors. We've done detailed testing. We don't see any genetic risk, but no doctor wants to put her on hormones.
Well, okay. This is where I would say testosterone. Remember, some of your testosterone aromatizes into estrogen. So sometimes just starting a little bit of testosterone could give them a little bit of estrogen that would be helpful without giving them the estradiol.
And progesterone doesn't increase clot risk, right?
No, it does not. It does not.
And we also have Dr. Dale Bredesen, who's been pioneering the use of hormone replacement therapy in older women for the prevention and reversal of Alzheimer's.
Yes. So
and other neurodegenerative diseases.
Because we need this for our brain. We are one big bag of hormones. This is why I also say to women, you can't go to your doctor and say, give me the test for perimenopause or menopause. They're just like, they wouldn't test me for that. I was like, well, there's a nuance to this. There's different things that we look at because we're a bag of hormones. You have to say which hormones we need to look at and pull that story together to give us the story of you. But yes, there's so much neuroprotection with our hormones.
This has been a great discussion, Dr. LaKeischa.
Thank you. My pleasure. Same here. I've enjoyed my time.
How can listeners, viewers find out more about you, get in touch with you, work with you, or use some of your programs?
Awesome. Yes. If you want to be one of my hormone hotties, go ahead and grab the freebie that I always give out. It is Cracking Your Hormone Code. It is hormonequiz.co, and take your hormone quiz and crack your hormone code. After you do that, you will get an email that invites you to make your virtual consult visit with me by going to talkhormones.com. And that's the way that you can get in touch with me. Now, you can follow me on all social media platforms at Dr. LaKeischa MD. That's DrLakeischa MD.
Great. And do you also have a podcast, or you had a podcast?
I do. I have my Hormone Hottie Hotline podcast. So you guys can come on and listen to that on any of your favorite platforms. It's where hormone hotties come and share their stories. I have experts like Dr. Ben here to come and give their expert opinions. And then I give my corner, the corner of a perimenopausal doctor, because I'm in the fight with y'all.
Great. Thank you so much. Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.